Cornea. I hope as soon as I start this topic, a lot of students who have already passed their third first would be smiling. Smiling because there is a familiarity to this topic. Cornea is usually the one of the earliest topics that we cover in our MBBS. We are well versed with it. A lot of questions are asked in third year. So we have read it somewhere. So there is a knowability, right? Now, how will we be proceeding with cornea in this lecture? We divide cornea into 4 parts. Number 1, we have to study the anatomy of the cornea. But as we all should know, if we have seen the lectures previously, the anatomy has been covered in the basic anatomy lecture. Basic anatomy of eye lecture. It has already been covered. So if you have not seen that, I will ask you to please go back, see the basic anatomy of eye lecture, see the anatomy of cornea discussed in great details, almost around 35 minutes, and do your anatomy from there, not repeating the topic here. The second subsection of cornea is that whenever we have a corneal pathology, what are the special investigations which we will have to do to be able to ascertain or diagnose our disease. So the second topic will be special investigations pertaining to cornea. And after that, the third topic in cornea that we'll study will be the most studied pathology in our MBBS days, that's corneal ulcer. And lastly, we will cover some miscellaneous conditions or other pathologies, we can say, like keratoconus, etc. Okay, guys. So this is the way we will divide cornea and we will study. Part 1 already done. So let's start with special investigations of the cornea. That is part 2 here in this lecture. Okay. Investigations. So the first investigation that I want you to know is called as keratometry. Wherever we find the word kera means cornea, guys. Yes. So keratometry has to do with something, measurement of something in the cornea. Now, what am I measuring from keratometry, everybody? Corneal curvature. Corneal curvature. Yes. So my cornea is a convex structure. So the curvature of the convex structure is being measured through keratometry. What is the principle on which keratometry is based? Very simple principle. If we remember, cornea is transparent. Because cornea is transparent, cornea acts like a mirror. So, the anterior surface of cornea acts like a convex mirror. So, the size of the image formed on this surface is inversely proportional to the curvature. So basically, the larger the curvature, the more the curvature. When we throw light onto the cornea anterior surface, the image formed will be smaller. So based on the image that we see forming, the size of it, we are able to ascertain the corneal curvature. Let's see how, everybody. The instrument which we use is this instrument. This is called as Bausch & Lomb. Bausch & Lomb is obviously the company, guys. So Bausch & Lomb keratometer. B&L keratometer or Bausch & Lomb keratometer. This is a manual keratometer. Obviously, as you will be able to make out, the patient will keep his or her face here. The examiner will be visualizing by throwing some light on the cornea of the patient. Now, when the examiner is visualizing, what is he or she visualizing? When the light is thrown from the keratometer onto the patient's cornea, this is what we are able to see. These are known as keratometric Myers. Keratometric Myers. Okay. So basically, through the use of a prism and some doubling rings within my keratometer, I am able to at last see 3 rings shining onto the cornea in green color. you will be able to see there are two vertical rings and there are two horizontal rings. These are known as Myers. Now, when we are doing keratometry, the main aim is to be able to focus these three rings or three Myers accurately or correctly. That is why we'll end up with such a question. What is the best or correct positioning of the keratometric Myers? Right, guys? Let's see. Option A. I hope option A is abundantly clear yourself. In option A, you will see one of the rings is not completely focused. Yes, we are seeing some overlapping of that ring. So that means this cannot be the correct positioning. Now, if I ask you to see option C, in option C, there is no problem of the focus as such. But you will see that there are two minus signs between the vertical rings. And there are two plus signs between the horizontal rings. It should not be so. Then how should it be, everybody? The correct answer is option B. In option B, if we look carefully, what are we able to see? We are able to see that there is a single overlapped minus between both vertical Myers. Okay? And there is a single overlapped plus between both horizontal Myers. So, after focusing the rings, that is what we try to do. We try to overlap the minus between the vertical and the plus between the horizontal. When we are able to overlap, then we say that we are accurately measuring the corneal curvature, vertical as well as horizontal. Am I absolutely clear here to everybody? Yes. So this is how we do keratometry, the instrument, what we see, and kind of an MCQ that can be asked on it, clinically oriented. Okay. Everybody clear about this? Okay. So once we know how to do keratometry, what we need to know are what are the uses of keratometry now. Yes? So obviously the first use that we all know of is to measure the corneal curvature. Okay, this we know. Now, the second use is it is also able to diagnose astigmatism. How? Let's see. To diagnose astigmatism, we have to see the shape of the Myers. The shape of the Myers, as we have seen in the above images, is circular. But if it is a case of astigmatism, you will see that the shape of the Myers will not be circular. Instead, it will become oval. So, if there are horizontally oval Myers, then it would mean there is astigmatism. But which type of astigmatism is the question? Horizontally oval means with the rule astigmatism. Similarly, guys, if my Myers are vertically oval now, then the answer will be obviously the opposite. That will be against the rule. I hope you don't need a photograph of the horizontally oval Myers or this is horizontally oval guys, this is vertically oval guys. Okay. So just you have to see the shape of the Myers. That's all. Then the third use is it can be used to ascertain the proper fitting of a contact lens. Whether the patient is wearing the contact lens correctly, that means is it fit correctly over the curvature or not. Okay. For that, I'll show you an image, guys. Let's see this image. In this image, if it is a good fit, we will be able to see a complete big Meyer here with all the positives and negatives. But if the contact lens is compressing the cornea at one end or the other end, we will see that the Meyer will always be distorted because of the steepness. You understand? If my contact lens curvature is steeper, everybody, it will press the cornea. It will press the cornea and that will distort the Myers. So an adjuvant use you can say, but nonetheless a very important use of corneal keratometry. Now, apart from this everybody, what other use can we have? The last important use, number 4 everybody, that we can get from keratometry is to diagnose keratoconus. We will discuss in detail at the end of our chapter keratoconus. But to diagnose keratoconus, keratometry can be used. If we do keratometry in a patient of keratoconus, we see pulsating Meyers. Pulsating Meyers means we are never able to stabilize the corneal image at one point on the cornea, everybody. It will keep shifting from left to right, up, down, everywhere. So it will disappear, it will come back at another spot. So we say pulsating Meyers. We see, we vanish. We see, we vanish. We see, it vanishes. Am I clear to everybody? So these are the 4 uses of keratometry. Please see everybody the images. Please remember this question that can be asked. Please remember all the image-based questions that can be asked. Very easy investigation. Corneal curvature keratometry. Moving on to the second investigation, everybody. The name is pachymetry. Now, pachymetry, all of us should know. Its main use, or its only use rather, is to measure the corneal thickness. The thickness of the cornea, everybody. So, when we are measuring the thickness of the cornea, what we should know is what is the normal corneal thickness. The normal corneal thickness is 0.54 mm. Okay? For a range, we say 0.5 to 0.6 mm. Or, if we say it in another mathematical term, it becomes 540 microns. That is the normal corneal thickness of the cornea. Remember, when we are talking about these figures, this is the central corneal thickness. See, we are majorly concerned with the central corneal thickness. Apart from that, corneal thickness will increase. Central to peripheral, the corneal thickness will increase. Am I clear? So all these figures pertain to the important central corneal thickness. Now, how do we measure the corneal thickness? We measure the corneal thickness by a lot of instruments which are just called pachymeters. They can be handheld instruments, they can be cumbersome machines, not going into all that. The end result that we are able to see in almost all the techniques that we use or all the instruments is an image like this. If you see carefully, this is my cornea, everybody here. This is my cornea. Right, guys? Now, this is what we are measuring, the thickness from the epithelium to the endothelium. We get a map here. You will be able to see in the center it is 666. As we go to the periphery, in this case, it is increasing to 673 here, 638 here, and various others. Okay? So we get a lot of data based on the various values. When do we do pachymetry? Why are we doing pachymetry? That is the question. So, uses I can say. Why are we measuring the corneal thickness? Number 1, in cases of LASIK. When we need to do LASIK, we need to ablate the cornea. Ablate means we are burning the cornea, so we are making the cornea thinner. So when we know that during a surgery we will make the cornea thinner, we need to be aware of the pre-existing corneal thickness. What if the cornea is already thin? Then we won't be able to proceed with LASIK. So, LASIK is contraindicated if corneal thickness is less than 450 microns. So that is why before LASIK it is mandatory to do corneal pachymetry. Secondly, in cases of IOP measurement, when you are getting a borderline IOP, high or low, everybody, yes, then you need to think about the corneal thickness. Why, everybody? Because as we should know that 1 mmHg IOP is directly proportional to 10 micron corneal thickness. That means IOP falls high if corneal thickness is more. IOP falls low if corneal thickness is decreased. Okay. So based on the corneal thickness measurements, our IOP measurement gets affected. That is why it is mandatory again to measure the corneal thickness whenever you are in doubt about the intraocular pressure values. Done, everybody? So that's all about our second investigation, that is pachymetry. Moving on to the third investigation, that is topography. Topography, guys. Topo means the surface. Topo, yes. So if we have ever seen a Discovery Channel or a National Geographic Channel, everybody, so there they have topographic cameras to map out entire large areas, everybody, where there is a hill or there is a river or there is a flat area, yes. So we are seeing the surface. So topography is done to examine the corneal surface, whether the cornea is smooth or there are some undulations in the cornea. Yes, as simple as that. Now, what are the instruments we use? First instrument, you will be able to see the image on the right side of your screen. This is called as a Placido disc. This is the most basic instrument, consisting of dark and light colored alternating rings, as you can see in the image. A light is thrown on this Placido disc. This light reflects these rings onto the patient's cornea, and we are able to visualize these rings. Let's see how, everybody. So, this is how a Placido discs work. This is a viewing aperture in the center with a lens. This is the handle which we are holding, and these are the rings of reflection. When we throw light on these rings are reflecting their image onto the patient's cornea, as you will be able to see in the image on the right side. Based on the shape, the size, the undulation seen in any of these rings, we are able to determine whether the cornea is absolutely smooth in surface or there are some problems. As you will be able to see, all these rings seem equidistant and there does not seem to be any undulation. For example, if there was such an undulation in this ring, that this ring was like this, then we would have known that there is an undulation in this part of the cornea, that there is an ulcer, there is some pathology in this part of the cornea. That is how simple Placido disc topography is. But apart from Placido disc topography, can we use other instruments? The answer is yes. So the second instrument that we used is known as orb scan. This is a machine based on a principle of slit scan imaging. Okay. So this works just like a slit lamp. It throws an oblique light and we are able to see each part of the cornea in scans. Not going into the detail, not important. Then the last instrument which we use commonly, guys, you will see this name being commonly used in the ophthalmology department if you are posted or if you have ever been into a cornea clinic, is Pentacam. This is a camera which gives us 5 measurements. That is the basic name, Pentacam, camera giving us 5 measurements. So this is more than a useful instrument. What else does it give us apart from topography? Let's see. So the first thing it measures is corneal thickness. The second thing it measures is corneal curvature. The third thing it gives us is the topographic elevation map of anterior surface of cornea. Then it gives us the same topographic elevation map of posterior corneal surface. So, through the use of Pentacam, you will basically be able to see whether there is a problem in the anterior or the posterior surface. Any epithelial or endothelial problem, both you are able to know through the use of Pentacam. And lastly, it gives us anterior segment imaging also. Okay? You are able to see up to the iris, if there is any problem from the cornea up to the iris also. Pentacam, 5 uses. Am I clear? But the main use is obviously the topography part. All the others are accessory uses of a Pentacam. Pentacam is again usually done before a case of LASIK is done or a LASIK surgery is done. If we have a keratoconus, we want to see the progression. Keratoconus is cone-shaped cornea. So whether the cone is progressing or not, if the cone is progressing, the topography will change. So in a lot of conditions like this where we have any shape or surface abnormality of the cornea, or we are about to do a corneal surgery, we always tend to do pentacam before those things. Am I clear to everybody? Done? So that's all about our third investigation, that is topography. Moving on to the fourth special investigation, the use of vital stains in the cornea. Now, why are we staining the cornea? That should be the question that you should be asking yourself. So there is a disease called corneal ulcer. Have we heard of this, everybody? Yes or no? Yes. So if there is a corneal ulcer, let's see everybody, let me try to explain it to you. Let's say this is my cornea. Okay. Now, ulcer basically means a wound. So let's say a wound has been created into the cornea, damaging its epithelium, a little bit of stroma and everything. Now, what you want to do? You want to be able to ascertain the size of this wound or ulcer. You want to be able to ascertain the shape of this ulcer. Cornea is transparent. So to be able to discern something transparent from transparent, you need to have some color or dye which will stain the part. Yes? So we can use a couple of stains. The first stain that we will use, you will see, will stain this. What are we saying? The base of the ulcer. Another stain can be used to stain the margins of the ulcer. So we have a couple of vital stains and some more also, which we can use in the diagnosis of corneal ulcer primarily. Am I absolutely clear about this, everybody? So let's start with this. The first stain, fluorescein dye. Fluorescein dye stains areas of denuded epithelium. Denuded epithelium, or I can say in simple English, areas where epithelium is abraded or lost. Okay? So that means, what is it staining, everybody? It is in effect staining the base of ulcer. Am I clear to everybody? By staining the areas wherever the epithelium is broken, it is staining the base of the ulcer. Now, this is a strip of fluorescein. So let's say this is a complete white strip of fluorescein with an orange tip. So it is an orange colored dye. Okay? We take a strip, we put it into the lower fornix, we stain the whole cornea or the surface of the eye. Then, if you see, we use cobalt blue light to illuminate. Okay? After we have illuminated this by cobalt blue light, everybody, wherever fluorescein dye is able to stain, those areas are visible as green color. So visible as green fluorescence. Am I clear to everybody? Orange colored dye, blue light, fluorescizing as green color. So if this is the part that the cornea is getting stained off, we know that this must be a case of corneal ulcer. Am I clear to everybody? No confusion about this? What are the uses of fluorescein dye? So number one, obviously, as we've just discussed, it can be used to diagnose corneal ulcer. Secondly, everybody, if we have seen the lecture on glaucoma, we know that this is used in cases of applanation tonometry. Specifically, if you remember, guys, Goldman's. When we do Goldman's applanation tonometry, then also we have to use fluorescein strips to stain the cornea. Then only we are able to do this. Thirdly, everybody, Jones dye disappearance test. Again, this has been discussed in detail on the lecture on lacrimal apparatus, guys. So this is one test which helps us diagnose the cause of watering or epiphora or hyperlacrimation. And lastly, Siddle's test. Siddle's test is a test which is done in cases of penetrating trauma. Discussed in detail again in the lecture on ocular trauma. Am I clear to everybody? No confusion about this, I hope everybody. Yes. So these are the 4 uses. Every chapter they have been discussed for you here to answer as an MCQ. Now, the second vital stain or the second dye that we can use is rose Bengal dye. Okay. Now, as you will be able to see the image here, everybody, this is the image which shows us rose Bengal dye staining. As soon as I use the name rose, we know we are talking about which color, red color, or we are talking about pink color. So we are able to see a stained area in red or pink color. Okay. That is telling us that we have used a rose Bengal dye. Now, what is rose Bengal dye staining? So, rose Bengal dye stains devitalized, or I can say necrotic tissue. Okay? Now, if we know the healing of a wound, how does the wound heal? From the base or from the margins? Obviously from the base. That is why our body has inherent mechanism to keep on clearing the base, everybody, such that all the necrotic tissue gets deposited in the periphery. That means at the margins. So by staining this devitalized or necrotic tissue, we are basically able to stain the margins of ulcer. Okay, everybody. That is what I had drawn. If we see carefully in the image at the top, the base was stained by green color fluorescein dye. The margins were stained by red color. That is rose Bengal dye. So if we remember this image, we are basically able to remember the use of both these stains. That is fluorescein stain as well as rose Bengal dye stain. Done, everybody? Now, there is another dye which is used very commonly these days. I'm writing the name. You may have heard of it. You may have seen it. Lissamine green dye or stain. Okay. In terms of the ability to work, this is almost same as rose Bengal dye. Why? Because this also stains our devitalized and damaged tissue. But it has the advantage. It is not toxic to healthy ocular tissue, as it does not stain them. Rose Bengal dye will be staining our lesion, but it also stains lightly all the normal ocular tissue, whichever is not damaged. So it can lead to toxicity. But Lissamine green dye is absolutely free from this healthy ocular surface damage. Yes, that is why these days we see it getting preferred over rose Bengal dye. But the main use of Lissamine green dye is to diagnose dry eye by conjunctival staining. I am discussing corneal vital stains, I know, but I am saying its main use is by conjunctival staining. Does not mean that it cannot stain the cornea. It can stain the cornea also, but the main use is in conjunctival staining. As you will see in the image here, everybody, in this area, everybody, the temporal part and the nasal part of the eye, you will see a faint green stain on the conjunctiva. This occurs in dry eye affecting the conjunctiva, leading to stippled appearance, everybody. Yes. After the conjunctiva is affected, then in the later stages of dry eye, you will see the cornea getting affected. And if we use Lissamine green dye in those stages, you will see stippled appearance of Lissamine green dye even on the cornea. But as a question, as an understanding, this is a very important tool to diagnose dry eye, Lissamine green dye. Done? Now, the last stain which we can use, everybody, is called as Alcian blue dye. You must have heard about this. You must know this name, everybody. Alcian blue dye is used to stain two things. Number one, any mucin deposits. So if there is a pathology in cornea on the ocular surface with mucinous deposits, then you have to resort to Alcian blue dye. Or in case there is some filamentous pathology, then you need to use Alcian blue dye. Am I absolutely clear about this, everybody? Yes. So the two important dyes that we have, which we use commonly, which we study commonly in our third years and in our MBBS days, is number one, fluorescein dye. Number two, rose bengal. The same job that rose bengal does is better done by Lissamine green dye, and it is one of the important dyes to diagnose dry eye, and Alcian blue dye with some accessory uses. Okay, everybody, done. Very important topic, corneal vital dyes or corneal vital stains, everybody. Moving on, everybody. A very simple investigation, confocal microscopy. You will not see this commonly being done. This is more of an experimental investigation, everybody. Very rarely done. It is used to visualize all the layers of cornea in vivo. Okay? So in vivo, if you need to visualize them, usually done for some kind of study purposes and all, then we use this investigation called as confocal microscopy. Period. Nothing else about it. The last investigation, everybody, which you have heard about, I hope, is called as corneal esthesiometer. Esthesiometer, as soon as I say, you know I am talking about what, everybody? Corneal sensations. So it is used to examine corneal sensations. As we know, corneal sensations can also be examined by everybody. Cotton, yes or no? Cotton wisp. Again, this cotton wisp and the whole corneal sensations fundamental has been explained in the basic anatomy. I hope you have seen it. Here I am just talking about the investigation, that is corneal esthesiometer. Yes. So this instrument, everybody, this image that you see, image A here, this is a pen-like instrument with a thin filament which comes out from this, everybody. Yes. The maximum length of this thin filament is 6 centimeter. The filament will touch the cornea of the patient. We open it completely first to 6 centimeters. We touch the cornea. We see whether the patient is able to feel the sensations or not. If you're not able to feel the sensations, we retract. I hope you are able to see this scale here, everybody. Yes. So we are able to retract this filament, everybody. We retract it by 0.5 centimeter from 6 to 5.5, 5, 4.4, 4. At whichever point the patient is able to feel the sensations, we record that. The smaller the length, that means more is the anesthesia. So I will write it for you. Smaller the length of filament which elicits the corneal sensations, it means lower the corneal sensations. I hope you understand this philosophy. Yes? That if I feel the sensations when 6 centimeter length of filament is touching my cornea, that means my corneal sensations are intact, absolutely fully. But if I feel sensations at 3 centimeter of the filament distance, that means my corneal sensations are lesser than normal. I hope we are everybody clear about the corneal esthesiometer. I don't think anybody will ask you the details of how to do it or how it is done. Usually they will focus on the images. They will ask you to identify the instrument or what is the use of this instrument. That is what the examiners will clinically restrict themselves to. Am I clear, everybody? These are the special investigations which we do in case of a corneal pathology. Part 2 of cornea is done. Now, using the anatomy that we have read and using these investigations, we will start to read the main pathology in cornea, that is part 3, corneal ulcer.